Mona Bhatia. I'm the Director and Head of Imaging at the Fortis Escorts Heart Institute in New Delhi. We shall be discussing the coronary CT angiography and the chest pain guidelines on how it is the class 1A indication today. We do know that if the level of risk is low for a coronary artery disease, the patient can be assured and may not need further testing. If the level of risk is high, the patient may need to go to the cath lab. But if the level of risk is intermediate, we want to have a non-invasive tool to evaluate the patient. And definitely there, the coronary CT has a role in establishing the diagnosis to understand the extent and severity of lesion, the anatomical and flow-limiting coronary lesions, and predict outcome and guide management. We do know that the negative predictive value of coronary CT angiography is in the range of 99%, but it's not only useful in ruling out coronary artery disease, but also with advances in CT technology, we now have the capability to look at stenosis so well that CT is better than most other non-invasive modalities in the detection and exclusion of obstructive coronary artery disease. But most acute MIs and sudden cardiac deaths are caused by low-grade plaques, and that is why we want to see the plaques. We want to evaluate the plaques which may possibly rupture. So the vulnerable plaque characteristics which we're looking at on CT are positive remodeling, spotty calcification, presence of a low attenuation intraplaque lipid core together with napkin ring signs, and plaque progression, all of which are indicative and may prognosticate adverse outcome. In the management of ischemic heart disease, we know we always want hybrid imaging. We want to have an assessment of the anatomical evaluation of the coronaries for stenosis, plaques, but also at the same time, we want to have a functional evaluation for ischemia. And CT does very well in both static and dynamic perfusion imaging to look for perfusion defects, be it by stress or rest imaging. Dual energy and spectral imaging further help. Combining the CTA with the CTP is tremendous because it gives an incremental benefit with almost a sensitivity of 100%. Recent advances also allow us to evaluate the CT-FFR, which then is excellent because compared to all other non-invasive modalities, it is the lesion-specific ischemia and is superior to all. So CT-FFR actually trumps all other non-invasive modalities for ischemia. In the prediction of outcome, we do know that CT also helps to evaluate situations such as the CTOs, where the success rate of intervention may be lower, and CT can guide whether the lesion is long, calcified, tortuous, possibility of visibility of the distal vessel with collaterals. All of these may impact outcomes. So definitely CT helps to look at not only the CTOs, but also overall ejection fractions, wall motion, wall thinning, together with the presence of scars. In post-intervention also, CT helps to evaluate complications such as in-stent restenosis, graft thrombosis, and so CT today has the potential to be that one-stop shop for imaging in coronary artery disease, where we evaluate the coronaries, the function, the perfusion, together with plaque imaging and prognostication. Not only that, CT is also now currently so useful in evaluating non-cardiac causes of chest pain, such as dissections, pulmonary embolisms, and situations such as pericardial problems. So all of these can be evaluated. So CT today is an extremely robust modality for accurate diagnosis, reliable prognosis, improvement in outcome. It's non-invasive, it's cost-effective, and totally acceptable being non-invasive. So definitely, CT today is the first-line test in coronary artery disease. Thank you so much.